Well, good morning and welcome everyone to this Master Plan for Aging virtual roundtable. My name is Adam Willoughby. I'm with the California Department of Aging. Before we get into the substance of the agenda, I'd like to do a quick roll call just so everyone can know who is here. So when I call your name, if you would please just indicate if you're here and the organization that you represent. So former Assembly Member Berg, are you with us? Okay. Pat Bitton, are you here?
I am here. I'm with Redwood Coast Village.
Thank you, Pat. Kim Coelho?
Hi, I am here. I represent the Alzheimer's Association.
Thank you, Kim. Cindy Claus John?
Yes, I am here with Redwood Coast Regional Center. Thank you.
Thank you. Chris Dart, are you here?
Yes, I'm here with representing Danco Communities.
Excellent. Julianne Eagle? Okay, Carmen Fong Chavez?
Yes, I'm here. Good morning. I represent Del Norte County Department of Health and Human Services.
Excellent, thank you.
Thank you.
Susie Frozzo?
I know it.
Oh, can you unmute yourself? There you go.
I just did. Sorry, I hit the wrong button. Here with the Area 1 Agency on Aging and Long-Term Care Ombudsman Program for Humboldt, Del Norte counties.
Excellent, thank you, Susie. Ann Holcomb?
Yes, I'm here. I'm the Executive Director at Food for People, the food bank for Humboldt County.
Excellent, thank you. Melissa Hoven?
Hello, everyone. Melissa Hooven, CEO, Humboldt Senior Resource Center and Redwood Coast PACE.
Thank you, Melissa. Amy Jester?
Hi, everyone. Good morning. Amy Jester, Program Director for Health and Nonprofit Resources at Humboldt Area Foundation and Humboldt Health Foundation.
Excellent. Maggie Kraft?
Good morning, Maggie Kraft with the Area 1 Agency on Aging.
Excellent. Barbara Leahy?
Hi, Barbara Leahy. I'm with Redwood Coast PACE as a part of the Humboldt Senior Resource Center.
Excellent. Ann Lindsay? Okay. Charlene Maisie?
Good morning, Charlene Maisie. I'm the Executive Director for the Del Norte Senior Center.
Excellent, thank you. Crystal Nielsen? Laura Olson? Robert Oswell? Kim Paris?
Good morning. Kim Paris, the Director of Nursing for Humboldt State's RN to BSN program.
Excellent. Thank you, Kim. Tim Ryan?
Hi, good morning. Tim Ryan with the North Coast Clinics Network.
Thank you, Tim. Marin Rose?
Hi, Marin Rose with the Area 1 Agency on Aging, Planner Contract Manager.
Thank you, Marin. Donalyn Showstrand?
Good morning. This is Donalyn Showstrand with Tri-County Independent Living serving Humboldt, Trinity, and Del Norte counties.
Excellent. Thank you. Kim Smalley?
Kim Smalley will be joining us, but she will be attending a little bit later.
Okay, excellent. Nancy Stark?
Hi, Nancy Stark is here. I'm with the Humboldt County Department of Health and Human Services.
Thank you, Nancy. Tony Starr?
It's actually Tori Starr. Good morning,
Tori
everybody.
Starr.
I am the CEO of the Open Door Community Health Centers serving Humboldt and Del Norte counties.
Excellent. Thank you, Tori. Latasha Talamontes? Dorothy Wadlow? Okay, so that's the end of my list. If I missed anyone, can you please say your name and your organization?
Hi, good day. I'm the Director of Social Services at Humboldt Senior Resource Center.
Great, thank you, Samantha. Anyone else?
And good morning, I'm Laura Olson. I'm with the Patricia D. and William B. Smallin Foundation. Sorry, I just missed my name. Thanks.
Thank you, Laura. Anyone else? Okay, hearing none, thank you very much. At this time, I'm going to hand it over to Assembly Member Jim Wood.
Good morning, everyone, and thank you for the opportunity to be with you today, and thank you for being here with us today. This is one of the many roundtables occurring across the state that will help inform the final recommendations for California's Master Plan on Aging. As most of you know, California's over 65 population is projected to grow by 8.6 million by 2030. That's an increase of 4 million from where we are today. To prepare for these changing demographics, Governor Newsom issued an executive order last year calling for the creation of a master plan for aging that can serve as a blueprint for state and local government, the private sector, philanthropy, to promote the health and well-being of older adults and adults with disabilities. Today, we'll have with us Dr. Mark Ghaly, the California Secretary of Health and Human Services, and Ms. Kim McCoy Wade, the Director of California's Department of Aging. Thank you. And the beauty of Zoom is you get to hear my dogs, and maybe you see a cat wander across the screen here at some point. So I just want to say thanks for all the local representatives, everyone for being here with us today. We're very fortunate to be one of the communities that will help Secretary Ghaly's team learn about the unique challenges older adults in rural communities face. In particular, to our discussion today, we're going to focus on healthcare and housing. I know we have a lot of participants, and I saw an incredibly ambitious agenda here today. So for the time we have, so I hope we can accomplish exactly what we're looking for. But we are looking at what are the challenges, what are some of the innovative solutions, and how can the Master Plan for Aging meaningfully address these challenges. So if Dr. Ghaly is on, I think it's time to turn it over to Dr. Ghaly.
Yeah, good morning, everyone, and thank you. It's a real privilege to be here with you, Dr. Wood. Nice to see you on Zoom. We talk frequently, but it's a pleasure to be with you and join you for this roundtable discussion. And to all of you for joining us today. I know that we will have a rich conversation. Agree that this is an ambitious agenda, but a very timely one and appropriate one. And Director McCoy Wade will share with you exactly how nicely this agenda aligns with some of the real focus that we've had from the larger stakeholder advisory group that has been meeting now for many, many months and actually had their last final meeting before advancing a report to my desk for consideration with not just within our agency, but within the entire cabinet and across state government and our various agencies for consideration. I will say that this is a timely issue. I often talk about our COVID challenges as the great unmasker and the great accelerant. And what we have seen from the very beginning is COVID's impact on older Californians, both those who rely on services and even congregate care settings on the one hand, but even those who are staying at home, who may have all of the financial resources that they need to do well, but the issues of isolation and some of the mental health and behavioral health challenges that have come up for older Californians. Really a privilege to have a chance to talk about that in our first topic around health. Then really moving into a conversation that I always look forward to as a primary care physician, pediatrician, but as a primary care physician who thinks about social determinants of health first and foremost. It's hard to not see clearly some of the housing challenges for so many vulnerable Californians, and looking forward to that part of our conversation today. So I do know we want to get right into the agenda, so let me turn it over to Kim, really my partner in crime, a tremendous leader for the state who I have to say, sometimes the leader matters, sometimes they don't. In this case, having Kim's leadership and her focus on engagement and bringing people together in a collaborative way really has been demonstrated throughout this master plan process, and really I think is going to carry us through to a very meaningful set of recommendations that I'll have the privilege to advance to the governor's office shortly. So with that, Kim?
Thank you so much. And I'll be brief, but I just want to thank the Assembly member and your staff. We have been working on this roundtable for 6 months. We were hoping to be in person in April and do a tour of all the wonderful, not all, but some of the wonderful home and community-based services in Humboldt and Del Norte. So of course we were really disappointed when that was canceled, but I actually think you all, you were onto something, because now you're getting the last word. Our final stakeholder meeting was last Tuesday, and their deadline for any other edits and comments is today. And so you all are getting the very last word in our formal stakeholder process. And of course, the conversations will continue. And we do hope to get back up there when we are back to some kind of new normal. I do want to just briefly share, Patty Berg, of course, served on the Long-Term Services and Support Subcommittee, so we're so grateful. And I see some longtime friends, Maggie Kraft from the AAA Network and Ann Holcomb from the Food Bank Network, which is my background, so wonderful to see you all. But I do want to share Patty and the other full committee's work very briefly. They submitted, at last count, 743 recommendations, which they were very kind to then also put an executive summary together with 5 major themes, which, believe it or not, your agenda is right in sync with, which makes all kinds of sense given the leadership and your on-the-ground expertise. So the first issue recommendation was about long-term services and supports and really bridging healthcare and community and social determinants of health, and to create an adult care system. Housing, I won't say more, we're getting to it. Third is poverty or downward mobility, a huge issue for the second half of life. Equity concerns across all the diversity of California, and of course in our rural communities. Diversity is also a huge piece, and thinking of the tribal partners in your land as well as other communities. And then leadership. How do we have the local and state, public and private, county and nonprofit, how do we all pull together for aging and disability? So those were their big 5 themes. We've got our 2 today, housing and health, and I can't wait to hear more from you. With that, I'll hand it back to you, Assemblymember Wood.
Okay, well, let's go ahead and hop into our agenda, which I don't have in front of me, but we'll let, I assume we have, and I apologize, so we have a panel here. We're going to discuss the first item, so we'll go ahead and move into our first discussion topic. Who's going to be leading that off for us?
Either way can work, Dr. Wood. You could start off with your thoughts about health, or we can take it from here. Either way to just kick it off and then open it up to the community.
You know, I'll start both of these with these topics with a couple of comments. Obviously, the challenges we face in rural communities around health is significant, and what I've always advocated for from the beginning of my time in the legislature is just our fair share of resources, quite frankly. And the other part of that, which becomes a challenge for us in our smaller communities, is sometimes the technical support necessary to actually take advantage of programs that are available to us. You know, in larger jurisdictions, you know, you've probably got entire departments that do nothing but grant writing and applications for all sorts of programs. And in our county, and I will say, you know, I have nothing but respect for the amazing people in Humboldt County and the incredible work they do. You know, we often find that the people who are doing one job are doing a million jobs, and that's what we face most of the time. So we often feel as though we're a little bit at a disadvantage. But I will tell you, there are no counties like Humboldt County that can actually, and Del Norte as well, excuse me, and I apologize. I'll just kind of lump my entire district into this because given the resources and a fair share of the resources, our communities can accomplish amazing things, and healthcare is one of them. And the biggest challenge I think we face continues to be providers, whether it's physicians, dentists, nurses, you name it, up and down the line. It's challenging to get people there. So you know, with that, I'd love to kind of turn this over on the other end and let others make comments. So.
Thanks, Dr. Wood. Before we get to general comments, I wanted to just build on what you said. I think, to me, there are tremendous opportunities through the master plan process to advance not just the issues or the problems with our system, but some real meaningful solutions, building upon programs that exist already, looking at those programs and understanding what's working really well, what could work a little better, and what frankly isn't working, and then advancing something that isn't, quote, new, but is iterative and really builds upon infrastructure that many of you have already put in place. And I think the master plan recommendations that I have had a chance to dig into already really suggest that. And for me, the issues around rural California and the counties, Dr. Wood, that you represent and many of you work and live in, I think do have clear differences from the counties that I'm most familiar with. I live in LA County. I've worked in San Francisco and LA, both super urban counties with its own share of challenges on housing and health and so many other issues. But I look forward to hearing from many of you about what you think, not just the issues are, but what some of the solutions will be, and especially those solutions that you think don't get enough airtime, so we can consider them fully as we move forward. So, Kim, unless you oppose, and she's saying she doesn't, really turn it over to the group to see who on the other end, from the community perspective, really wants to sort of stick their neck out and say, hey, this isn't going as well as we'd like, and here are some ideas for how to make it better. And I will just say that the state we're all kind of living through a crisis, not just a health crisis, but really, and not just an economic crisis, but a crisis of so many priorities and trying to move them all forward. So I'd love to hear if you feel like, hey, the number one priority is this thing, here's what it looks like today, and here's how we can make it better. I would love to hear that sort of soup to nuts conversation from each of you or whoever would like to start us off.
Patty, I see you have your hand raised. Can you unmute yourself?
I did unmute myself. I just want to, because you don't have the entire agenda on the screen, and I want to make sure that this one is covered. Under healthcare, Jim, we have what are some of the innovative approaches to partnering with academia to augment healthcare workforce focused on geriatrics, and that's why I wanted Kim Paris on the line. So that's not included on your agenda. It is on the one that I received, however. So I want to make sure that's covered. Did you hear me, Jim?
I sure did, yes. So we'll go ahead and see. We can start with that one if you'd like. Who out there would like to take a crack at that? I did want to before Kim. Okay, I want to just before Kim makes a comment. I want to say something here that I think is really critical to the challenges that we face in rural counties, whether it's around healthcare or housing or anything else. It is often the one-size-fits-all approach that comes from state government, and there's often limited flexibility in how resources can be used and you know, what is important in LA County or the Bay Area is not the same as what's important in our areas. And without that flexibility, it makes it really difficult. And I also believe disproportionately challenging for rural areas to try to figure out, okay, if there's dollars for this, but it doesn't really quite fit there, how do we make this work? And consequently, I believe we often lose opportunities and resources you know, as we move forward. So, and Patty, I know knows that. So Kim, please go ahead.
Thank you for having me, Patty. Thank you, as always, for putting me on the spot here. But, you know, I agree there's so much opportunity right now with the things that need to happen in healthcare. I am a huge proponent of team-based care and making sure that everybody on the healthcare team is trained to the top of their license, and in particular, registered nurses. And I think we still have a lot of work to do. Open Door Clinic has done a lot of work with that, but there's a lot that goes into that kind of a model that can really help the patient to have a team around them versus just a provider or a nurse practitioner and kind of seeing them as their go-to person. They could have a whole team around them, from a registered nurse care coordinator. And it wasn't long ago that I worked as a care coordinator and saw the value of what it looks like to follow a patient through their day to a doctor's appointment, into their home to see what's really going on in their home and why they're having a fall, to the food that's in their refrigerator, and looking at that whole person. And that's where I would like to take the direction of our nursing program, so that we as nurses and nurse leaders are having that approach to patient care where we're looking at the whole patient. And the piece about telehealth, I have two elderly, not elderly, I don't consider my dad elderly, but he's 81. And he is very, not in tune to telehealth or even texting or anything like that. I mean, he uses Facebook and things like that, but I also had an uncle recently who passed away. And when COVID came, it made it even more challenging. He was isolated, living alone. He didn't text. He didn't know how to work his computer. We had the telephone and that was it. So I think we need to ask our aging population what they need, and maybe it's focus groups, but also looking at each patient from an individual perspective and thinking about how we can meet the needs of that person in front of you, because everybody's different. And then one last thing, I know there's hands and people are eager to speak up, but the reimbursement piece of it, we've got telehealth now, and providers are looking at having better reimbursement for that. But I think we need to think about how registered nurses can get reimbursed for providing care coordination and telehealth and those kinds of things. And so behind that is building policies and procedures and things to make that safe.
My screen, I'm not able to monitor the hands up, so we'll go on the honor system. If people have got something to say, please just jump in, and if it gets too unruly, we'll find a way to mute you all, I guess. So,
Jim, this is Susie Fischel, the Long-Term Care Ombudsman Program Manager. I'm coming at it from a person who works with residents in nursing homes and assisted living facilities. I wanted to make one comment. I truly agree with what Kim Paris had just said. I support that. But I think one of the things we lose when they go into nursing homes is patient-centered care. What is it the patient wants, not what is it the doctor or the nurse or the physical therapist wants. And so often multidisciplinary teams sit down with a resident perhaps sitting in the room, but the resident really loses their voice. So we work really hard to make sure that they have that voice, but I just really want to stress patient-centered care, not just in nursing homes, but also out in the community. And the other thing is telemedicine. While it works great for us, Kim hit right on it. The seniors that I work with really are limited, one, in access to laptops, tablets, computers, and then they lack the skill to use them. And then the facilities lack the staff to assist them. And I think telemedicine can be a great asset to the residents that are able to comprehend that. By using geriatric experts throughout the state, if we can tap them into those folks, because we don't have a lot of them up here. But I just think it's a great opportunity, but we need to look at how we're going to provide the staff and the equipment for these residents in nursing homes to access the medical care that they need and that they want as we continue to provide for them in the end of their life. And that's just my comment about healthcare right now. Thanks, everyone.
And this is Tori from Open Door, if I can add on to that a little bit. It's interesting. I love the first question about access, because that's really kind of our primary goal that we have as an organization, is improving that. And the more I do this work, the interface between housing and health is inescapable. And the more I look at it, the health of a community is based around housing. And if we don't have really safe, adequate housing for a community, then you really can't have health at all. And we're starting to run into that. We've actually been really successful recruiting recently. We actually filled our last advanced practitioner position. But what we have problems with is retention, because really trying to find places for people to live long-term and raise families and become embedded in the community and stay with us is based upon housing. And then that also impacts all of our patients from the standpoint of, do they have safe, adequate housing? And if they don't have that. So it's, the more I look at this, the relationship between housing and health is, we can't separate that. And so the work that I'm actually doing as CEO is really trying to look at development around that. And part of that is so that we have enough workforce that actually will be able to stay in the community to serve the community from that standpoint. And I'll build upon, we've learned a lot. I mean, as interesting as COVID has been and as challenging, it's opened up our ability to try to look at utilizing telehealth. And certainly the difference between a video visit and a phone visit is profound. And we're actively working to try to make that really a video type visit. But we run into so many barriers from a technology standpoint, and especially in the rural areas, our access to broadband, whether it be just from the infrastructure, I'd like to actually point that out, or the cost for people to connect to that infrastructure. And then of course, all the ability to know how to access it from, you know, the technology itself for the geriatric population has been a challenge, but I know we can overcome all of those. And then while I have a moment and I have you here, Dr. Ghaly, I'll just mention that, you know, the 340B program and the changes that the state is proposing around that, and then also the assault by big pharma on a federal level is really disruptive to us as community health center providers. And that revenue stream will have a significant impact on us if it continues to be further disrupted and limiting our access to be able to provide care. So I think there's lots of opportunities here, and I'm so glad to be able to participate in this, and housing and health are interrelated inextricably. So thanks.
This is Dr. Ann Lindsay. I'd like to comment. I was a primary care doctor in Humboldt County for 28 years, and as I grew older, so did my patients. And I have a number of elderly patients living alone in 2 or 3 bedroom houses who were actually lonely and miserable in many ways. And as a result, I got a focus now. I'm working with a number of people in the community on Life Care Humboldt, which is a new organization to establish a life plan community here with independent living, assisted living, memory care, and advanced nursing services in one location on one campus. And one issue is for us is that there are no regulations that allow the small house or greenhouse alternative to skilled nursing. And a greenhouse, all small house would be 10 to 12 bedrooms with 2 or 3 staff, and a common, every bedroom have their own bathroom and a common living room and kitchen. And there is the pilot program that the Department of Public Health has been carrying out has not had results for some reason. That the small greenhouse model or small house model is less expensive to run. It's more pleasant for residents in many ways, and it has advantages for preventing the spread of infectious disease. That there are a smaller number of residents, so the pool of people is smaller. That there are also smaller number of staff, so they're not, you know, rotating and exposing themselves, and they actually build a more intimate relationship with the residents. And so the evidence seems to be that the staff have increased the amount of accountability for taking care of themselves outside of the facility so that they don't bring COVID and other infectious conditions in. So it would be a big help if those regulations were promulgated and we could have something like that here.
So this is Charlene from the Del Norte Senior Center. I just want to jump in here and kind of, I mean, it's easy to see based on how the conversation just went from health to how we house people, that these two subjects are not separate. I agree 100% that reimbursement, Medi-Cal, Medicare need to be more flexible in terms of what kind of care setting they will pay for. We live, we're lucky that we live on the Oregon border, but we manage an independent living, HUD subsidized independent living apartment complex. But when people get to a point where they can no longer be safe in independent living, we have to try to place them in Oregon, because Oregon Medicaid will pay for assisted living. California Medicaid will not. It's silly to have to do that. We're lucky enough that we're on the border and we can make that transition a lot more easily. But we need to start, again, patient-centered. If the patient doesn't need a skilled nursing facility, then they should be able to be in a facility that's more meets their needs. But I also want to talk about, before I leave that, COVID definitely made it clear that just the structure of aged care facilities need to be changed so that they keep patients safe, and not because it's more convenient for staff and the operators to warehouse seniors basically in rooms or in places where it's easy to spread disease. So I think just even the design of how we design licensed care facilities has to be looked at. But being in Del Norte, I have to put it out there that you can't even lump all rural counties into the same pot. We are vastly different from Humboldt, and we cannot just be an extension of Humboldt County, which happens a lot in people's minds. We have a different set of resources. We're much smaller. We're much more isolated. We have lower median income. We have, we don't have a university in our county. We don't have the same level of education in our population. So the differences even among rural counties has to be taken into account. And, the capacity to deal with funding that is so siloed and has so many administrative requirements. Maggie and I have conversations all the time. We receive funding through Area 1 about the Department of Aging and the regulations and the reporting requirements and the silos that come even from the federal money. And then finally, the population-based idea that fairness is, if you have more people, you get more money. It doesn't always translate to being able to meet the need. And, it costs as much to build a senior living facility in Del Norte County as it does in Humboldt County, but you're going to give me less money because I don't have as many seniors. So that's a lot of stuff all in one statement, but resources is a huge piece of it, and we have to find a different way to allocate so that the need is met everywhere, and not just you don't have as many people, so you don't get as much. So those are my thoughts. Thanks. And thanks for inviting me to this.
And thank you for being here with us and your perspective. I think it's really, really valuable. I just wanted to jump in on and piggyback on something that you said, and that's around the finances and the resources. I think everybody assumes that living in rural counties is cheaper. And the reality is, in many cases, it's not. You have challenges with transportation, so that means that a lot of our patients have to go further away to get specialty care. But just even the cost of a lot of goods and services are not lower just because it's a rural county. And I think that there is that misconception that is the case. Fuel prices, for example, are higher. Groceries are going to be higher. And so those are things that are important to seniors as well as anybody else who's of any age out there. And so these are things that often get kind of left, or misinterpreted, I guess, from my perspective. I will add that, I have 5 very unique counties that I represent, and Trinity is roughly 1/3 of the population of Del Norte, and a huge county. And then Mendocino also actually lower population than Humboldt, but in many ways 2 distinctive population centers: the central part of the county, and then the coastal community, which is very, very different. So I guess the challenge around resources, and then I see we're kind of blending our discussion items in here, so it's always a challenge. But I think you're beginning to see really how all these things are intertwined. So we're still technically on that first question, but we really aren't anymore. So is there someone else who wants to jump in? And yeah, please.
Again, I'm Samantha over at Humboldt Senior Resource Center, and I'm pretty firmly rooted in a behavioral health and social work context. So I think when you're talking about access to healthcare, even before COVID impacted us the way it did, it was difficult for older adults and individuals with disabilities to get the quality behavioral health care that they deserve, not only because there's less providers, but the people who are available to do the providing. All my interviews with them, and as a graduate of Humboldt State social work, Masters of Social Work, the opportunities for mental health, behavioral health internships are supremely focused on children. When you do get an internship that's focused on seniors, you don't often get the opportunity to build those clinical skills. So Humboldt Senior Resource Center, Melissa Hooven and Barbara Leahy and myself, we've been thinking about ways to actively engage with our amazing university, starting with the social work department, hoping to move into nursing. They have that person-centered care approach that's already built into most of their education, and partnering with them maybe to give them incentives like, how can we give them slightly paid internships? How can we give them more clinical opportunities that aren't with places that they don't want to be, building up that workforce where they can actually learn the skills for that specific population and then maybe get a job afterward. Being part of innovative research about intergenerational pairings, anything that you can do to partner with them. And I think we're lucky because I'm from here. A lot of us that work here are from here, and we have people who really want to do this work. And before COVID hit, we got to present to some social work students, and we had about 8 or 9 people who were interested in coming to work with us, and then we just couldn't accommodate it. And so I think thinking about that as we're moving forward is something that's in my mind.
Dr. Wood, Brian, I wanted to just offer up, I think you've probably heard common themes, Dr. Ghaly, throughout the state around access and issues with infrastructure, housing, and the connections we've spoken about. But something that may be unique to the rural counties is this lack of infrastructure, and this idea that both systemically and infrastructure as far as a community, but as businesses. My biggest concern is that we're starting to push the social determinants burden onto healthcare providers who are completely overwhelmed. And how do we start to leverage as a community some of these resources and these assets that we have that do great work in the community-based organizations, but really pull them all together so there's reimbursement? Because the concern right now is it's being lumped onto an already pretty full plate with the infrastructure that exists within healthcare. And I don't know how much we can keep pushing on these professionals before they're saying, look, I got into medicine. I really wasn't into transportation or food vouchers or housing or some of these other items. So just thinking about the rural economies of Humboldt or North Trinity counties in Dr. Wood's area, the infrastructure doesn't exist. You're not going to go to specialists. You're not going to send them to Kaiser. But more importantly, you don't have the community-based organizations and to all be supportive. So anything we can do for alignment throughout the state, whether it's from Eureka to San Diego, to get consistencies and maybe even some clear role and delineations for what's reimbursable for this type of organization, what's reimbursable for this type of organization, and then let us as communities put those together to make sense. I think we have, as our colleague up in Del Norte mentioned, lots of different assets in Del Norte than we do in Humboldt County, as there are in Trinity, but really trying to leverage people where they're at and use those existing infrastructures. Thank you.
We're doing our best here not to jump in, but we're nodding, you're sparking so many ideas and connections and conversations. And so we want to keep hearing from you, but there's just so much that we're resonating with.
Yeah, we're so two things I'll say: the benefit of masks and the benefit of mute. We can say all sorts of things like, Tim, right on, this is exactly what we were thinking, or Samantha, to your point on the behavioral health workforce and a real opportunity, really tying back to what Ann said earlier. I mean, there's so many dots that you guys have connected, and I know it was in LA, but I ran something called Housing for Health for a long, long time. And although a different focus that was really on homelessness, I think what you are all saying is that housing for health, right? That it is inextricable part of health. With that said, let's keep going. I think so much rich conversation, and Tim, just to really lift up your point, and we've been thinking about exactly what you said, and appreciate some of the perspective that you just shared.
This is Donna Lynn Shostrom with Tri-County Independent Living, and I'd like to talk a little bit about telemedicine. In some ways, it's been a good thing with COVID-19 that different providers have expanded their ability to provide telemedicine. But as people, as an organization that works with people with disabilities, we'd like to remind everyone that telemedicine is not a substitute for an in-person visit. When you have a person who has hearing impairment or vision impairment, the telemedicine is not equal. Not only do we have problems with lack of internet access in many of our more rural areas in Humboldt County, even Arcata, for example, there is internet, but in some places the internet is unreliable and spotty. And as we've all had so much experience now with video conferencing, if your internet goes out for a moment and you miss part of the conversation, you can lose the whole context of the conversation. And then if you throw in that somebody is hearing impaired, they can completely lose the gist of the conversation entirely in a telemedicine. So it's not just access to internet, it's access to reliable internet. We are, as the lady from Del Norte was talking about, I think that was Charlene, how different Humboldt County is from Del Norte County, how different Humboldt and Del Norte County are from the Bay Area in the way that we interact with people, the way that we establish relationships and do business. We're still more a handshake kind of county. We deal with people face to face. We judge people based on personal interactions. And the people that we serve, the elders in this skilled nursing facilities, for example, they are not only not used to this technology, there are trust issues that come up as well using technology and not having that face-to-face contact with people. One of the things that we're doing is we have taken some of our funding and bought Chromebooks, and we're taking those into the skilled nursing facilities and helping them establish their Gmail accounts so that they can have access to Zoom, telemedicine, socializing, shopping, searching for housing, whatever it is. But one of the problems with that is we loan them to them, and there's a lack of security for their personal possessions in a skilled nursing facility. And so that's a concern. It's a risk that we're taking now. And obviously we don't have enough Chromebooks for every person that's in a skilled nursing facility. When we get to the topic of the effect of COVID-19, two things for us. We are not able to move people out of skilled nursing right now, which is one of the things that we do. People who are stuck there because there's not adequate housing, they really don't need skilled nursing. So we try to get them out of the SNFs. But right now, the other thing that's happening for our clients is they're in independent housing, but they're not getting the support that they need. They're not getting the care providers they need. And they are at dire risk of now being institutionalized because of COVID-19. So I just wanted to point those things out from a disability perspective. Thank you.
Donalyn, I wanted to follow up on the Chromebooks. We had the opportunity to provide those to from the state. One of our concerns, again, was the security of these books, these Chromebooks, and the ability of the residents to use them. Again, that gets back to the lack of staffing to help walk them through the steps of using something that most of them aren't familiar with. And again, trust issues are a problem when they think they're talking to somebody on the phone. Sorry, I have to close my door.
This is Maggie, and one of the things when I think about housing, we have, and Chris is here with Danco, and Danco has done an excellent job of harnessing funds and resources to develop subsidized housing, senior housing, and they've done a terrific job. We see people who won't qualify for that housing, who remain in the open market for rentals, and are renting housing that is just not suitable for people with disabilities, people who want to age safely in place, people with anybody who doesn't want to go upstairs every day, or they has arthritis and can't open the door. There's all these factors, and I think our county, at least Humboldt County, the number of new housing that has been developed in this county has been really, we are not keeping up with the housing demand, just like the rest of the state, although in some parts of the state, they're building pretty quickly and they can't keep up. We're not even building quickly. And so if you have a lot of money and can buy, buy a large home on a piece of property out there, that can happen. But as Ann alluded to, you have these older people living in homes that they raise their kids in, and they, in some ways they'd like to get out of that home and get something else, but they can't find it. They can't buy it. And so those houses are not being opened up for the people that Tori's trying to recruit to move up here to start families and live. So, I mean, we've got this bottleneck, and it's not just the low. I mean, we need more low income housing and subsidized housing, but we really need affordable housing. And when I use affordable, I'm not talking about subsidized. I'm talking about affordable to people across the income brackets that we have. And we seem to not, we're working hard on the low income, still not enough. If you've got money, you can get what you need, but it's all the rest of us who are going to land mostly, many of us are going to be in that income area. So I wanted to say that is really an issue for housing. And some of it is, it's about local, local rules. And, I know some of the cities are looking at infill and are doing it, Arcata is filling everything in, but again, it's subsidized housing. It's not what's affordable for somebody just above that. So I think we're going to have that constant challenge, and people aren't going to leave their homes if they don't feel like they have a better place to go to. And then they end up in a nursing home because of that fall and that broken hip, and boom, here we have a different path for people. One of the things that strikes me, and I don't know when this happened, but when I moved up here in '88, to start running the ombudsman program. And I've been working down in senior services before that in Sacramento. And we're having the same conversations that we had in '88. The difference is there's more, we're all older, and Tori's laughing because he was there, and Patty was certainly there. And I mean, a lot of us were there, and we're having the same conversations. Now we have the COVID overlay, which I think has brought up a lot of why we're having the same conversations. And I think, it's around ageism and ableism, and it's around discounting the experience of people with disabilities and older people. And, when you look at, COVID as a great example, well, it's only really impacting older people. Whoa. That's huge. That's us saying, our society saying it's not a big deal because it's only impacting older people. That's, to me, that was a wake up moment. And I think we have to get into the schools at a young age, at a constant, consistent young age, and be reframing the messages, not just around racism sexism, but around ageism and ableism. We have to start reframing it, because we're sitting here at the end result trying to deal with this, where I think the aging service sector should probably be spending a lot more time infiltrating the service sector of the youth and starting to normalize. And I'm not talking about some adopt a grandparent program, which I think is great and can serve someone really well who doesn't have an older person in their life. I'm talking about systemically infiltrating and talking about these things so that it's not, you know, it's going counterculture against a culture of youth and looking at this. But I mean, I know that's kind of this big, but I'm just saying that we've been having these conversations since before I started working in aging services, and we will continue to have them unless we start digging down into those isms around what's acceptable to say about people who are older, people who have disabilities, people of color, whatever. So I just wanted to put that out there that we could, if we put some money in the front end to really be working on what we think about people as they age and what we think about people with disabilities, then we might be not having to have these conversations on the back end. Just a thought. Thanks.
So this is Charlene. I want to piggyback on a couple of things that Maggie said before I forget. When talking about the housing, brought the light into my head because it wasn't what I was focused on here. We also are the designated provider of low-income household energy assistance program and the weatherization piece of that. And we are so limited in what we are allowed to do under the weatherization program that we often have to defer homes because they're in too great a need of repair. There is nothing in Del Norte County that we can access to help people fix their homes up. And this isn't just about older people. It goes the gamut, that if somebody could just come in and rehab their house, they would have a safe and secure place to live. But all of the programs that are meant for that, CDBG does housing rehab, Home does housing rehab, they're all very regulation intensive. The county doesn't want to administer them because they're difficult to administer, and they expect them to be loan programs. And so you get people who already can't afford to fix up their houses. They're on low income, they're on fixed income, they may be disabled, they may, just be unemployed. And you're asking them to take out a loan and pay off a loan in order to get their house fixed up to where they can live in it. And that's just unconscionable. To me, there should be a grant program that will allow us to fix people's houses up. We're improving the housing stock. We're improving people's health. We're decreasing the chance that those folks are going to become homeless if their house falls down around them. And we're not burdening them down the line with debt that they're never going to be able to pay off. And that the counties have to administer those loans for 30 years or more. So that, to me, is a huge piece that's missing from our toolkit. The other thing that, Maggie talked about, I don't think it's just ageism. I think there's a culture in the United States of, we don't take care of each other. You're responsible for taking care of yourself. And we only address things when they become a severe problem. It's like the difference between preventive health care and going to the doctor when you're sick. We just don't look at prevention and taking care of each other and making that a priority over, well, when you get super old and you can't take care of yourself, then we'll put you in a home. Or when you get super sick, we'll put you in the hospital, but we're not gonna invest in keeping you well. So I think it's a big cultural shift that isn't just about ageism, but it's just about how we view who is responsible for keeping us all healthy as a society. So I wanted to let that before I forgot.
So I'm just a bit of a time check. We're at 10:55, and could we go back to the agenda for a minute? If Adam, if you can pop that up, or someone, so we can. I want to make sure we're covering topics here so that we don't miss something here. So obviously we've been talking a fair amount about housing, and I think that is obviously hugely important, and there's no way to discount the connection between healthcare and health actually and housing are is critical. So I do apologize too. I had to move. I live in an area where there's a lot of construction, and it just so happened everybody decided that they wanted to be pounding nails and running power saws, and so I had to move to my unfurnished spare bedroom here. I'm sitting on the floor with my back against the wall, so it looks a little austere, but it's quieter back here. So, but let's go back to the discussion of topic number one for a minute, and see, as we look at these questions that have been put out there, if people have any comments about the healthcare workforce focused on how we augment healthcare workforce focused on geriatrics, and then also just what has COVID done from your perspective? And I think this is a really important one. Is that I'd love to hear Tori pop in there and others that talk about what has COVID done to affect the availability and access of healthcare. So if a couple of people want to jump in, let's see if we can hit those topics, and then maybe circle back to a couple more areas on the housing.
Kim, this is Patty. For you and for Mark, I want you to know that Tori runs Open Door Clinic, which is the largest healthcare provider in Humboldt County. Sees more people than any primary care group ever. So he should be the one to help lead that conversation off, both in terms of the challenges associated with the ability, for older people to access care. I mean, some of the issues that we're dealing with that, as well as the COVID pandemic. I think he really should be the one to lead that one off.
All right, Tori, you're not on the hot seat or anything.
You are totally on the hot seat.
You are totally on the hot seat, so
fine.
Go for it.
Patty's an equal opportunity person, so and I'm delighted to actually start the discussion. And it's interesting. COVID actually has done a lot of good because it finally took away the barrier to doing improving access, because it's always been a reimbursement issue, right? I mean, we know the technology to do population health management is not about having somebody show up in a clinic to be seen, because that's the way the reimbursement makes it happen. So our ability now, I think our access to care has increased and will continue to increase and allow us, because I believe that the reimbursement changes will become more permanent, and that will allow us to actually help more people because they won't have to travel into a clinic. So it has revealed the weaknesses, though, in the infrastructure. And certainly we have to really learn how to set everything up for an effective video visit relationship from that standpoint. The other thing it's really shown us is the social isolation impacts. So people have become even more socially isolated, and that negative aspect that it has on health has been really out there. We have people just calling people for merely to check in, right? As part of our approach when we had to move people from working in person to remotely, just to be able to have people stay connected from that social standpoint. So I think it's been a real blessing from the standpoint of how we can do true population health management and focus on wellness. Some of the best advantages have been for the mom with 2 toddlers and a young baby and got an ear infection. She doesn't have to pack everybody up and haul them down to the clinic just to be able to see the doc and get some antibiotics, right? I mean, so I think when we think about, and the impact on that from an economic standpoint, right? The lack of disruption from somebody having to take time off from work, all those kind of things makes a whole lot of sense in a bigger picture. So I think COVID has revealed the importance of social connections and the impact of social isolation, and then showing us that really it hasn't been a technology issue, it's been a reimbursement issue to do population health management. So I'll see what other folks, and before I head out, I just want to put a plug in because I'm on the economic resiliency group for the 4 northern counties. And this has to do with housing, but our businesses in general, and it probably is a conversation for Congressman Huffman more because only the feds can print money. But I'm really worried about the access to capital for businesses to be able to restart. That is going to be crucial, and I don't quite know how to do that, and that impacts our greater health also. And then access to capital for just like what Charlene said and others about being able to have access to capital, especially to start housing, is going to be important. So I'm really worried about how that's going to play out in the long run. So I'll turn it over to other folks.
Well, Tori, since we're on a health center theme, I'll just give you a couple quick highlights. One of the more interesting things that we've seen with COVID is when I represent the federally qualified health center group, the health center control network for the area. We used to see around a 20 to 25% no-show rate for behavioral health visits in person. And we've seen that drop down to about 3 to 4% through Assemblymember Wood's district, which is a dramatic savings for us both. You know, we're not taking the occupied time, but what it is allowing us to do is to start to triage the patients that physically need to come in through our doors while simultaneously taking the behavioral health that don't necessarily need to come in. And so maybe the more creative we can get about when does it make sense to physically come in and touch a body and look at diagnostics versus is it a worried well, is it an earache, as Tori mentioned, is it something that can be done with a physician's licensure that says, hey, we're gonna have to get back on track here, and we can't have, when COVID's released, thousands of people who have pent up demand who have been waiting to get in the door, and start to think about what is the best way to start funneling people through. I'd like to get back to start talking about prevention again, and that seems like a long way down the road for a kick. But the idea being is that there have been some strides that we've made. The challenge being is that a lot of these pivots that we have to be nimble providers means that we're putting lots of money in infrastructure, whether it's electronic health records to be able to document it, it's the technology, it's the providers. But if we're going to solve this workforce challenge that we have throughout the rural area, we've got to leverage some of this technology and make smarter decisions about the limited resources we have. And I think that's probably where this group can really start to hone in, is identify that patient population, what services and who can do what the best, and let us all let each other lead as well. Thanks.
I would like to address the issue. Somebody brought it up about reimbursing nurses, RNs going into nursing homes to care for these residents. Currently, one of our physicians up here, who's amazing, has a patient load of, my gosh, 150 patients because there's just not a geriatric provider up here. And she runs between facilities, which means each resident really doesn't get the attention that they need because these folks need some hand-holding, perhaps more so than you and I might. But if we could find a way to reimburse nurses, not that doctors aren't important, but I've worked with doctors and nurses, and sometimes nurses know more than the doctors do. Sorry if there's any physicians out there, we love you. But it would be really helpful for them to be able to get in, and I think we would have more of a supply of providers if we could somehow figure out how to make that work. And I'm specifically talking about nursing home residents, not folks in the community. Thanks.
Maybe we could step back a little bit since we have you here in front of us, Dr. Ghaly. I know the state would love to go to an alternative payment model sooner than later. It really makes a lot of sense, and we are actually supportive of that. I would much rather focus on outcomes than health. But for the rural areas to be successful, we're going to need some help with infrastructure development, business intelligence, you know, our ability to really look at our populations, make sure we can access the population via remote, you know, telephonic type things. So that infrastructure, like Tim talked about, investment, whether it be, and then we don't have to worry about reimbursement for specific things. It's like, pay us per population, we'll figure out the best way to be able to serve that population. But we will need help in the rural areas. That model will not work the same for urban and rural.
Yeah, Tori, I'll just say I have been, as you were talking, and many others, especially as you bring together the linkage between housing and health. When we go to that alternative payment model, which is really how do we stop saying show up in a clinic to get paid, rather let's focus on population and individual outcomes, bringing together what is broadly public health with clinical delivery system health. I think not only does it open the playbook, as I think you're talking about on the healthcare side of the equation, but it allows you to naturally intersect with some of these other social determinants, other areas of concern, even as far as housing, right? So the partnerships that I always get most excited to start between the housing developer and the healthcare provider. And that was the kind of concept behind housing for health in many ways. But as you know, Tori, very clearly, and I think a number of you know, the movement towards sort of liberalizing all of our thinking around an alternative payment scheme, like everything new, people fear leaving what they're used to. And COVID, I think, does, if we use it in the way that you're talking about it, Tori, not just as the really unfortunate, unexpected event that it's been, but also as the catalyst for much needed change. And Maggie's comments about 1988 feeling like it is today, I agree with the concept of really digging in around norm setting and reframing the message. So we have young people who are going to have all of our jobs in that period of time kind of think about it differently, but also being able to leave our safe place when it comes to the way programs run, the way we've reimbursed, because I know that at least I can speak for myself and our agency, and I think this is shared with Assemblymember Wood and the entire governor team, right? Many of us want to figure out how to get to outcome-driven programming rather than widget counting and pay for this or that. And I really liked Charlene's point earlier about the diversity among rural counties being really important. And I think that's going to have to drive some of these alternative approaches as well. And I'll tell you, one of my biggest struggles today is how do we create a as some of you know, in about an hour, I have the privilege of sharing where counties land and their COVID data. And it becomes this sort of can't wait to see, is my county making the move? Did we meet? All of these interesting things. But I'll tell you, one of the biggest challenges has been, how do you create a data system, a monitoring system that can meet all counties' needs? And clearly a group of your mighty supervisors from small rural counties is saying, maybe you can't, and maybe we need something different. And that conversation is, I think, a microcosm of the one we're having now, right? That even as we approach an alternative payment model for all clinics across the state, maybe what we do in certain parts of California is an alternative to that alternative, right? It's that it doesn't have to be that one size fits all to get to some of what we're talking about.
Tim or Tori, would you mind jumping in here, because I think I want to frame something for Secretary Ghaly and Kim there. What can you give me an estimate of what the percentage of population the clinics serve in Humboldt and Del Norte County? Do you have a handle on that?
Yeah, we serve roughly 60,000 unduplicated patients in Humboldt and Del Norte. So that's a little less than half, I guess, if you look at total population between Humboldt and Del Norte. But primary care, we are certainly it.
I've got some numbers for your district if you're interested, just from the federally qualified, obviously Open Doors, the largest. About 70,000 patients total, of which 12,600 are Medicare, 50%, 32,000 Medicaid, and we've got an uninsured rate of about 10%. But I think maybe the point brought up earlier, we have a 25% private insured, and that's unheard of in community health centers, and especially federally qualified health centers. That's very much a rural reality where we see everybody regardless of ability to pay or ability to pay versus some of the other demographics. So were there specifically numbers you were looking for, Dr. Wood?
No, that was just, I wanted to, because I think if you look at those numbers compared to more urban areas, I think they're very different. Certainly, I live in Sonoma County. Those numbers are not the same percentage-wise, and so I think our more rural counties, we see more care being provided, whether you have insurance or whether you rely on Medicare or Medicaid, provided in federally qualified health centers and rural clinics, and so that creates a different dynamic there. I think it's important. And I want to just go back to, and I've heard this a couple times around an issue around prevention, and it has been a constant frustration for me since the day I walked into the legislature to realize that we don't really do a lot of investment in prevention, and so we end up paying for the treatment of conditions and diseases, and but not preventing them. We also don't do as much as I believe we should be doing on preventing people from advancing from one living setting to another, whether it's a living setting where they're in their own homes and going to assisted living or straight to skilled nursing facilities. And so even things like we tried, a year or so ago to try to get an enhancement to the home upkeep allowance program the idea came from many of the people that are on this call here today. And, the fact that people, might be in a skilled nursing facility or be in a hospital for a while and have to be in rehab in a skilled nursing facility, yet they live so close to the poverty level that that a little bit of help would keep them from having to advance permanently to a setting like that. Yet we can't get the resources for even something as simple as that. And that is, and that's where, I go back to, if we had resources and we had the flexibility to do what is the best for our individual communities, it would be a real help for counties like ours. Anyway, I want to interject that there. I don't want to steal anybody else's thoughts there. So see, where are we on time here? We are at 11:11. So we have 19 minutes remaining here. So
hey, Dr.
Can we go?
Wood,
Yeah.
I don't have that much. I'll probably have to jump off around 11:20. So if there are things in particular that I should hear from folks, I would love to hear them soon. And obviously Kim will stay on through the duration, but thank you.
Yeah, please, if you anything specific for Dr. Ghaly, please, now is the time as the clock is he's got to get to the green room and got makeup and all these things that are important for the next.
So this is Charlene. Just while we're on the kind of the reimbursement and the redesigning healthcare, I think we also need to expand the definition of what is healthcare. Both Humboldt Senior Resource Center and the Del Norte Senior Center run meal programs that are funded right now through the Older Americans Act. But that is healthcare. We get people who come out of the hospital and they're referred to our program because the physician knows they can't prepare their own meals. It's part of their discharge plan. It's part of their recovery. It's preventive health care. And we should be able to build that to a medical reimbursement, whether it's private insurance or Medicare or Medi-Cal, to be able to help support. The money we get from the Older Americans Act only funds about half of the program costs in order for us to serve our community. So we're constantly scrambling to try to find the funding for the other half of that need. The other thing that we find challenging, especially again with our independent living apartments, is we are not allowed to assist anyone with any kind of activities of daily living, or we become an assisted living facility and we have to get that licensure and that whole 9 yards. So we can't even hire somebody to come in and help with housekeeping. And it's not always easy for these folks to find their own help. And we have, even with in-home supportive services, we've had IHSS caregivers that we don't want in our facility. They're not, they create problems. They're not screened well. They can be pot stirrers among the tenants. And so, but we can't, there's nothing we can do about it. And we can't hire somebody ourselves, otherwise we become an assisted living facility. So I think looking at some of those limitations on how can community-based organizations support the aging without having to be a licensed care facility would help too. And better reimbursement. There's a gap between people who qualify for IHSS and people who can afford their own in-home supportive people. There's a gap of people who can't afford to hire somebody, but they don't qualify for IHSS. But again, that little bit of assistance can keep them in their own home as opposed to having them have to go into a long-term care facility.
I think anything, piggyback on that, anything that we can always be looking at how you can unsilo funding. I think a lot of what we're going through here and talking about is that we get money for this, but not for that. And it's been, it's a big issue when in a rural community, when you're trying to put parts of things together to make a whole, and yet then you're jumping through all these different regulations, even though the money's going into meals or whatever it is. And it creates, for programs, small programs, it just creates a workload that is similar to the workload in larger counties where they're getting millions of dollars. I mean, it takes the same amount of time for my fiscal director to fill out the forms for CDA for, $900,000 as it does for somebody to fill it out for 3 times that much. And I think rural, and that's our program. I'm sure it's a similar function for all of our comparatively smaller services here. And, I think of the PACE model where, and that's not an easy gig either, but the idea was take your Medicare, take your Medi-Cal, put it together and pay and spend it the way it makes the most sense for those people. And not an easy gig because Medi-Cal and Medicare have lots of rules that they have to follow. But the idea that we start looking at, even, people with private health insurance, is like the people making decisions about how this money gets spent and what is best for those people are people who are trying to manage a profit. And so it puts a lot of us in that situation where we're trying to provide services to the for-profit industry for people who might need meals at discharge and might need their health insurance company to pay for that, but they're not going to because, so I think it's just, that may be out of our bailiwick. We may be having to look at government funding in this process, but anything we can do to allow more flexibility with how money is used to meet the needs of the people the money is meant to serve. And and that's a government, that's a state level issue, but it impacts us hugely.
Yeah, I'd like to jump in on the food and nutrition issue as part of the whole person. We, as a food bank, are serving over 700 seniors on a regular basis monthly, and 400 of them are part of what used to be the Senior Brown Bag program that lost funding over a dozen years ago. And most food banks I know have continued to operate the program without any state funding. We're all focusing on grants and so forth, but food insecurity is such a major healthcare issue for our seniors. It's amazing to me the number of our local clinics that all have food pantries now because they see what a significant issue it is and they want to send people home with food if that's part of their health risk. I know we've been able to form some partnerships here and there with groups like Resolution Care who will come and pick up and deliver to folks that they're serving. We'd be happy to partner more with healthcare groups, but it does get really tricky funding wise in terms of trying to expand those services when there isn't a pot of money that really applies to us. I know there's money for the Meals on Wheels program, and we do partner with them and provide some extra produce and things like that. But it is limited. And we're seeing some seniors who are homeless and living out of their cars, living in very marginal housing situations, and that home delivery oftentimes makes a huge difference in assessing what's going on so that we can then connect with a relative or whoever we know of who is connected with that person to do some follow-up. But absent those formal relationships, it makes it a lot more challenging.
Hi, this is Crystal from Del Norte County Social Services. I administer the HSS and APS for Del Norte County. I would like just to chime in on a few things and piggyback off what the theme of what's going on is. You know, I think we need to be proactive instead of reactive. I think as a society, we are reactive. And from my perspective, working this for 15 years, the elderly is always, the aging population has always been the afterthought. And it would be nice if we were able to move the realignment funding, if we can make some funding that is protected for that class, for the aging population, because we don't have that in the realignment. If we do, it's very minimal. We have the IHSS. It's they get to pick and choose who they hire. So, you know, going off with Charlene is sometimes it's not the best fit. If we had healthcare that were able to support these transitions for our elderly population, I really strongly believe you would see less adult protective services abuse, less financial abuse, because what happens when they can't stay in their own home, they have the funding sources, they become reliant on people, and then people take advantage of them, or they start neglecting themselves. So, you know, I think if we looked at it as not reactive, but, you know, more as a preventative measure, that we would be able to see every system, every facet of their lives and have a better quality of life. I think one of the big things, I think Tori maybe was saying about isolation. I think that's the big thing that we've seen in adult protective services is that isolation, how it's negatively affecting our aging population in Del Norte County. Not everybody has transportation. That's a huge issue for rural Humboldt and Del Norte County. They don't have their cell phones. They don't have electronics or knowing how. So I think if grants to be able to support them, and that would be amazing, so they can be connected. It's very difficult work that we are all doing, and we just all have to be real resilient to make that work.
Hey, Crystal, thank you. Dr. Wood, I do have to get going. I just want to just thank you for hosting this and inviting me and including me. I will say these conversations, each one is a little different, and each one has its really strong lesson for me. I'll say what is refreshing is the collective really mindset that the resources coming together in a flexible way will allow you, the experts in the community, to drive towards outcomes that are meaningful, not measured in visits or other sorts of important process measures, but not outcome measures. And for me, getting to opportunities where we at the state and at the county level support such work to happen, I think is tremendous. So we will certainly, I expect a lot of what we heard today to be reflected in how we move forward. And this notion that California isn't one size fits all resonates even more today. And I just want to be really appreciative of all of your energy and the work that you do, not just sharing with me, but day in and day out for so many Californians who need your help, need your support, and depend on you. So thank you very, very much. And I look forward to hearing how this wraps up.
Thank you so much, Dr. Ghaly. Really appreciate you being with us today, and best of luck on your noon briefing. So, but I do want to, and we'll have just a few minutes left here to sum up, but I want to kind of emphasize a couple of things. Number one, you've heard the desire and the need for flexibility in some of our rural counties, and all of our rural counties, quite frankly, because we are each, I often joke, and I mean no disrespect to any particular county, but I feel like I represent 5 counties from 5 different mothers. Every county that I represent is distinctly different in its needs, the demographics, the geography, you name it. And so to have an overarching, one-size-fits-all approach to dealing with really a lot of complicated issues is really not effective. And this, I want to just commend this group of people on this call are amazing, dedicated professionals who have incredible stories to tell and have done incredible work. But I think one of the overarching things that I always walk away with when I meet with and talk with folks from this group is that given our fair share of resources on things like this, these folks can accomplish huge amount and for the care of people in our communities. And so the struggle is just getting our fair share sometimes, and those silos and those hoops that people have to jump through make it really, really difficult. And so as you look at this master plan, my hope is that you can find ways with rural communities to build in that flexibility, because it's a critical component.
Well, I couldn't agree more. And I guess I want to speak to a couple things. One is the home and community-based services, how we bring together health care and social determinants of health. Right now, I'd say we're working the problem from 2 angles, because we know it requires state and local partnership. One is what is allowable for Medicaid? What services can be paid for Medicaid? So this point of meals, is it only medically tailored meals, or is it nutrition, health at home? And so you've seen the administration, those of you look at the CalAIM proposal or long-term care at home, we'll have to do another Medicaid proposal, but how can we make sure that Medicaid pays for this expansive, flexible, evidence-based definition of health? But then the other side, we know from the local side, is that for the health plans to engage with the great diversity of community-based groups, there needs to be a way for you all to come together into some kind of infrastructure so that it's easier for the health plan to engage with you all. We have a couple models in California, Partners in Care Foundation in Los Angeles County, and a little bit Institute on Health in the Bay Area. But it's one of the things that the AAA network has asked us to look at with you all is how can we help communities form these intermediaries or collaboratives that then become a one-stop shop for the health plan so that they don't have to maintain lots of contracts. And also there is that care coordination role that's come up so many times. So figuring out that the whole chains, yes, state permission, yes to the health plan, but then how do you make sure it gets to the local providers who are truly serving the people? That whole chain needs to be worked through. And we're hoping to partner with, as I mentioned, C4A to do some research and piloting on that. Specifically on aging, I definitely want to own, I've been the director about 1.5 years, and we are looking at a lot of those issues Maggie raised. We're calling it AAA 2.0. We need to move away from all the contracts to an allocation. We need to look at the base allocation. We need to look at, right now we do it to 33 areas versus 58 counties versus another way to do it. And so we are going to look at all of those things because we know that for the master plan to be successful, the local aging and disability networks need to be strong. That's where the work happens. It's where the magic happens. So how we can be supporting you with the resources and this infrastructure in that sense is clear to us. There's no master plan success without a strong AAA and disability network, and then a CDA up here with your back and hopefully amplifying your voice as well. So just a couple thoughts from the home community-based services side. Our health plan partnership is so critical, and then our aging, the foundation of the Aging and Disability Network is ready to move past 1988, is Maggie Kraft, channeling Maggie Kuhn, if I can give you that credit. It was great to hear your remarks. Thank you very much.
So I just want to, this is Charlene again, I just want to kind of put something out there for you guys at the state level to kind of look at. We are also the designated agency that receives community services block grant funding. Mm-hmm. I have been so amazed at the model of community action and community services block grant, because it truly is as bottom driven as I've ever seen governmental funding be. And by that, I mean that we are given parameters of these are kind of the things that we want you to work on. It's outcome driven. The federal reporting is all about outcomes and, you know, what did you do in certain areas, but it tells you, you can work on, these are the multitude of things that are allowable that you can do. You tell us in your plan which of these things you're going to do and what outcomes you're going to expect from what you're going to choose to do. So there isn't this top-down, you shall spend X amount of money on meals, you shall spend X amount of money on in-home support, you shall spend X amount of money on information and assistance. It gives you a menu kind of these are the things that we think are important and we want you to focus on. But it's all driven by planning at the local level. So that area plan that Maggie has to do every year truly means something. We have public hearings on those area plans and they really don't affect, they're meaningless because it doesn't matter what the community says, the funding is driving what we can do.
Well, and I'll just, I know we're at time, but those, right, that currently, as I understand it, is the federal Title III for nutrition, et cetera, et cetera. I will say, COVID, all the CARES money has not had that. The CARES money is spend it across. So I do think there's a chance for the feds and the state to learn from that and see, so what happens when you empower communities to use it flexibly versus drive it down in title channels. And so that is something that'll definitely be taken forward for older Americans going forward. What do we learn from CARES flexibility that we can take forward? Just like telehealth. What else can we, what is the only good thing to come out of this is growth forward, hopefully.
Great. Well, I just want to say thank you to everyone. I know our time has come to an end here, and there may be things that we didn't touch, but I think this sort of a freewheeling discussion hit on a lot of the critical themes that we're feeling. We have tremendous resources in Humboldt County and Del Norte County, and I hope that going forward that you reach out to us and some of the people who you've even seen on this call here today, because there are some really amazing programs that happen. And I have personally been inspired by this group to carry legislation in the past, and I know that going forward I will continue to do that because this is an extremely important segment of our population, and we've heard this before that often is a bit of an afterthought, and I don't think that's appropriate in any way. So I'll continue to advocate on my end and look to these folks for inspiration and support, which I always get. And I hope that moving forward that we really can find a way to accommodate the individual challenges that we face in some of our different communities. So.
Agreed.
So thank you so much, everyone, for participating. I'm sorry it's not in person because I think that Kim and Mark would have benefited tremendously from seeing some of the amazing programs that are available in our counties. And but I think I'm glad we got the last word. And sometimes the last word makes a big difference. And so I will be anxiously looking to as the plan comes forward and being an active part in the implementation.
Absolutely,
so,
we're counting on it.
Great.
Thank you.
Thank you so much, everyone. Have a great day.
Thank you all.
Bye. Bye-bye.
Bye, Patty.
Bye, dear.